at the end, and we'll just have kind of a dialogue, so please get to the microphone as we go, and we'll kind of go through these real quick. So the other thing important to know is we speak for ourselves. We're not speaking on behalf of the collaborative, the survey organizations, ACOG, the state of Texas. These are our own personal opinions based on our experiences as either surveyors or as being surveyed. So I think that really, you heard this morning, how many of you know what QAPI stands for? How many don't? How many of your colleagues don't? So when the survey organization comes through and asks, tell me about your QAPI, and they look silly and they don't know what that means, that's a problem. So really everything related, my impression is at least, and we'll see what my colleagues think, is the QAPI is the core of everything for your maternal program or your neonatal program. Everything should be feeding into it, from bedside outcomes to what do you do with an adverse event or an event that happens, how are you reviewing that at your facility, and what are you doing to document that as far as interventions or approaches to remedy that. How would you guys?
Yeah, I would totally agree. I mean, I think as you, just one little correction to the introduction. So I haven't actually surveyed a hospital yet. I'm due to do that, but I have been surveyed at 2 hospitals. And so Carrie and I work at I work at 2 different hospitals, and we work together at one of those hospitals. And so I have gone through 2 different surveys, and as you're preparing for it, you kind of get as Dr. Toy mentioned earlier, like the 121 elements that are going to ultimately be considered met or unmet once the survey is there. And really looking at them, there's a huge focus on quality, which is rightfully so, right? That's exactly what the purposes of this whole designation process. And so when you go through it, you really see that the focus is quality, but the term QAPI just kind of gets repeated over and over again, and it may not necessarily be the term that we have all historically used to describe things, but when you get into the fine print, you see, you may already be doing all of this, but I think the important point is to be able to eloquently describe what you're doing, and it's not just that you have a quality improvement committee or that you're reviewing cases. It's how do these events that happen at the bedside get, somebody realizes, I can't even think of a good example right now, but something happening at the bedside that someone realizes is an issue, then what is the process for getting that to your quality specialist team? What do they do with that information? And then how do they disseminate that information back to everybody else? Because it's not good enough for just having a core group of people know all of your QAPI efforts. And then when they go on the tours, none of the nurses, none of the residents, they'll ask the residents questions. They'll ask anyone that they come into contact with. And if they don't know what you're doing with that information, then it's not as useful if what happened at the bedside, if the improvements you made don't get translated back to the work being done at the bedside.
The only thing I would add to that is the process of being surveyed is supposed to make you better, so they will the process will find any gaps that you might have in your quality process so that you can improve it. I think that can be a little hard for some of us because we want to be perfect. And if there are 121 different rules, we're going to pay attention to the 4 that we missed out on. But the point is to make us better. And obviously so much of that is the quality process. So coming in and figuring out where weaknesses exist that you might not even realize, so that you can become better.
And I think the other message would be, if your hospital has a quality department, that won't cut it. It has to be in your unit, embedded in your labor and delivery unit or in your neonatal unit, and looking specifically at metrics you're looking at besides core measures. They're not going to take core measures by itself. You're going to have some other bedside metric or some quality improvement project for your unit to look at, and show what you've done with it, and show documentation of that as well, as we'll talk about. Our second pearl was that the maternal medical director and the maternal program manager are core to the QAPI. So they need to be, those 2 individuals need to be involved in each of those meetings, as many as possible, and have documentation that they participated, that they're reviewing credentials for the nurses, reviewing for the physicians, and that you can prove that to the survey teams when they come in.
Well, I should say they represent the army behind the whole group of people that need to actually do all of that work. So obviously there's a lot of people, If I think through my hospital and everything that makes up our QAPI, it goes into so many different people that have important roles, but then at the end of the day, it's those two roles that have to answer for everything during the survey.
And I think, the person who serves in that role can be a different function at each hospital. For example, Carrie and I are both maternal medical directors for our hospitals. Carrie is the chief of obstetrics at Taub. I am not the chief of obstetrics at TCH Pavilion for Women. I'm the chief quality officer there. So it's when you go through what you think that the MPM and the maternal medical director, what qualifications the rules say that they have, it may be a different position at each different hospital, and that's okay. And whoever it is, that person should be involved very early in this whole process, and they should be involved together, because again, they are really kind of the face of everything that is done at the hospital when the surveyors come.
One other thing on this, many of you might be in a bit of a different spot, but I would say the documentation and sign-in sheets and proof of everything, we weren't prospectively doing in all of these areas until we realized we had to prove it. But as part of the survey, showing that your maternal program director and medical director are at every single one of the majority of your QAPI meetings, and that their name is on that sign-in, and that anything that you are using as a quality meeting, you can prove who was there and who was involved. Starting to do that now, if you haven't, it is really important, because if it isn't documented, it didn't happen.
That was a perfect segue to the next lesson. Just the minutes of meetings, any policies and procedures, make sure you've got that documented somewhere, because the surveyors will come in and they will look at this patient on their web portal that you're looking at with their patient care, and they're going to go back to that policy and guideline to see, did you follow that or not? And they want to look for consistency or deviations where things are all over the place. So really good documentation is really critical. For a lot of these guidelines, we may not have had in place before, as Dr. Toy mentioned. So there is some leeway, I think, to just have an action plan in place that you're doing this now and moving forward. Doesn't mean you have to wait a year to do your survey. Just get your processes in place and start doing it now. At least you can show to surveyors when they get there you have these in place, and we've implemented this on January 1st going forward.
The only other thing I would add to that, the documentation, is not only documented, but know how to find it when you need it. And so the binders that Dr. Toy talked about, yes, we had reams of binders at both hospitals. And they were very organized, but you had to have somebody who knew where to find what you needed. But one of the things in terms of making those binders, some of it is just minutes that you can print from an email. But, if you had a debrief on a patient where you have handwritten notes, what you want to do when they're looking through charts, and if they ask, did this patient have a quality review that went with it, you'd like to be able to find the quality review, if there was a debrief, what was said about that. And you could have the best notes in the world, but if they're in random stacks of paper or random piles in your office, and you can't compile them and put them together, then that's not going to be beneficial. So as you do, whatever you do, not only document, but file it in a way where you're going to be able to find it and produce it when you need it.
So we didn't rehearse this, but that leads into effective navigators is the next lesson. That was so critical. We applied for a level 4 center, and we had a bunch of people looking through charts at once, and we had a bunch of nurses there. But having a dedicated nurse or even 2 nurses or some kind of navigator who knew the EMR, not asking me where to find the anesthesia record because I couldn't find it, but somebody that could navigate all that and pull it up real quick for the surveyors, that was super important. And when I surveyed some other organizations, and my colleagues probably can attest as well, that was critical, because if you can't find it, it doesn't exist as far as the surveyor concerns. Pro number 5, verification means, means show me the evidence. I think you heard that from Dr. Toy this morning. The surveyors are just there to see, are you in compliance with those 100 and some elements for whatever level you're going for. And they're going to look for evidence of that. They're going to be going through the charts to see, okay, this patient had sepsis and was admitted to the ICU. Did you follow your guideline for that? Did you do what you said you did? So they're there to just really verify, and they have to see the evidence of that. And if you can't show them the evidence, you'll fall short of that objective. One thing we did at our center, and I think was really helpful.
I was going to add about the, maybe a little bit about the 30-minute
Sure.
people arriving. So many of our, the rules have who needs to be available to be there within 30 minutes. Of course, the one that I'm most familiar with is the level 4, because that's what our hospital was applying to. But being able to prove that if you've got what you require, you say is an urgent request, that somebody is there within 30 minutes. Most of the hospitals I had practiced in before, that wasn't something that we document. So figuring out how to prove it actually took building it into our EHR and doing things by paper. And so it was that one took a lot of time for us to have ahead of time. And so I think it's something to make sure you can prove. So not just what are your reasons for an urgent request and who has to be able to do that, but how you prove that they are there in that time period. And even after a lot of time building it into our electronic health record, it wasn't ready to go live in that format before our survey. And so we had to spend time doing it by hand to prove it. So I think that one's a really hard one to make sure you focus on and you internally decide what your criteria is going to be. It's created a lot of good conversations around our facility. It's part of now what I orient. We're a teaching facility, and I know not everyone is that way, but these are the things now that I say to our residents, or I think this could work in other formats, like when you're going to escalate. If this happens, we consider it an urgent request, and this is when you should be telling this other person who is your backup in a timely fashion. And so I think it's helped us a lot in that structure.
Yeah, that was one of our other lessons learned is really be precise about what your definitions for urgent request is and what's the response time and who's responding. Because the survey teams will come in and they'll look, did you follow that? Was the attending notified? Was the chief resident notified? Was whoever was supposed to be notified? And was it tracked in the right time frame? We struggled as well with documentation of trigger to intervention. And that was an ongoing process. We're trying to get it in our EMR, so it's been largely just documented in the written notes, so it's hard to track. But that's probably the biggest challenge I think a lot of us have had. And the other thing I think it's important to know what the triggers, these are things that the QAPI probably needs to be following too, because if you say you're intervening for hypertension within 60 minutes of a severe range pressure and nobody's tracking that and that's considered an urgent request, that's probably a shortfall.
And it may even be too that this is all happening, but you just don't have a consistent place to find that documentation. So, just know now, starting today, going forward, that you could identify that. Like if you have a rapid response team, and at one of my hospitals, we can push a button on a smart panel, and that goes out to the hospital system-wide. Like the cell phones. And so those are things that can be tracked. But if you called me at home and as the MFM backup and said, Dr. Davidson, I need you in urgently, I may have been there within 30 minutes, but it was never something that we wrote before. So I've now gotten in the habit of saying, once I eventually get there and take care of the patient, the note is, I was paged at this time and notified of this request, and I arrived at the bedside at this time. And so that's something, I've been MFM backup for like 15 years, and that's something I'd never written before the past few months. So just thinking of things going forward of how you could track these.
The other thing we found useful, another one of our lessons was do a dry run, including chart audits. Very illuminating to do some of your own chart audits and compare it to your guidelines and realize, oops. So you'd rather do that before the survey teams get there so you can at least be prepared to address issues before they get there. My colleagues are giggling here too. But I think that's really important. And use your higher level centers around you. Somebody who may be surveyed already, don't be afraid to ask out for help for getting prepared, or if you're part of a hospital system, utilize the other hospital in that system that may have been surveyed already to kind of come in and audit your processes and look at your guidelines and see what they think. Another lesson is educate the unit. We're all frantically creating guidelines and policies to meet the designation, but if our teams don't know they exist or they can't speak to it, it doesn't exist. We found that problem at our center for a few things that were kind of new guidelines that we had created, and we just had to have an action plan afterwards to come up with how we were educating the unit. But make sure the whole team knows what QAPI means, Quality Assessment Process Improvement Committee. Make sure they know what designation's all about and why they're being asked questions by the survey group, because they will walk through the hospital. They will ask residents, nurses, unit clerks, medical students, tell me about your environment here, tell me about how you manage sepsis and those kind of things, or other.
I would just add, despite the fact that it's not supposed to be stressful, it is.
It's
And
super stressful.
I would say the thing that I likened it to was like going through 2 solid days of oral boards. So, and so I think that's where we hadn't done a dry run, but if you imagine, you might have somebody who is absolutely brilliant and knows exactly the QI structure of your hospital and is integral in making it happen. And if somebody comes and asks them in a way that puts them off and they're a little nervous, they might not remember what to say in that moment. And so I think that's where the dry run really can happen, can help a bit to relay that, just like many OB physicians will practice doing oral boards so that you're not as nervous when that comes in. And so I think that's a really good recommendation.
You know, the other group to or groups to educate are the places outside of labor and delivery where they might take care of a pregnant lady. So somebody in the OR, somebody on the anesthesia service, somebody in the ER or the ICU. And as I recall, there are educational requirements that each of those units also has some sort of educational activity. And if the first time they hear about it is when the surveyor's asking them if they do it, everybody has kind of a funny look on their face. So.
And that's an excellent point because, you know, Taub is a trauma hospital, and so obviously the tour was around the hospital and the various different ICUs. And then TCH Pavilion for Women is Texas Children's Hospital. It's a women's hospital within Texas Children's Hospital. So we even went to, you have to be flexible too, because the first day as they're going through all the charts and kind of gathering information, they may want to see and do different things on the second day than you had actually planned. And Pat's laughing because he surveyed us.
I don't think you're supposed to say that.
Full disclosure, yeah.
And so we had to change up the tour for the second day based off of things that the surveyors wanted to see. And so we actually ended up in the TCH, the PD side emergency room where traumas would potentially come in. And they actually, one of the surveyors asked one of the nurses, tell me what IPASS is. So you never know where you're going to end up and what question is going to be asked. So it is very important that any service, any place in the hospitalization that could potentially touch a pregnant woman knows that this is happening and is prepared to participate in the visit at a last minute, late notice.
And there's no way to figure out your vulnerabilities until you're preparing for that and knowing what to improve.
Our next lesson was, and Dr. Toy alluded to this before, personalize your hospital guidelines for your maternal unit. I think good examples of that, as Dr. Toy mentioned, was the resuscitation policy, just having a hospital-wide one that you're using that doesn't address the pregnant woman, perimortem, cesarean delivery, could be an area of concern. Disaster response, probably can't use the hospital one unless it includes how you're gonna get pregnant patients out or NICU patients out. Massive transfusion protocol, at least if you're gonna use the hospital's version, at least adopt it as your obstetric one. So just some of those bigger guidelines should be personalized to your unit, and again, educate as well. So part of our action plan for not having a resuscitation policy that addressed perimortem C-section is we educated our unit, but we didn't educate the trauma unit, so we didn't educate the ICUs and all those things. So we have to go through and do all that for those other service lines. So going back to that education piece, anybody that touches a pregnant woman needs to be aware of your guidelines and educated.
I would just add on the disaster response, making sure you simulate it and practice it. It's one of the things you're supposed to have done, but we had never actually simulated having to evacuate our labor and delivery before we were preparing for this. My labor and delivery director isn't here, so she can't correct me when I say this. I think that was one of the more fun days that I've been through in a while when we had to practice what it would look like to evacuate our L&D. Clearly my definition of fun, very different from hers, but it was really eye-opening, and the sleds that we had used to evacuate pregnant women, we had to figure out and make sure we all knew how to use them, and we knew where our different fire barriers were in our hospital. And of course, I am in Houston, and we just went through Harvey, so we should have known all of these things, but we had never actually got to the point of simulating each individual little part of it. So as you develop new guidelines, simulating them, I think, is a really good way to make sure you know what they would look like in practice, especially if they're things you don't use very often. And we completely adapted because of that and because of the things that went wrong in our simulation.
And I think the simulation part's really important. That's in the rules to do drills. So having things set up for that, that's one we didn't really anticipate very well that we're doing right now. And a shameless plug for one of my colleagues and my wife at 5 o'clock. She's doing a session on OB simulation. So we talked about urgent request as one of our lessons. And then I think Dr. Toy alluded to our last lesson is that surveyors evaluate and the state designates. So as surveyors, we're just there to collect information. We just check off the list. Do we think you met this by our survey or by our audits? And then we just send that information to the state, and the state makes their decision. And then the final pearl, or the last pearl, is don't delay. There's 100 or 200 and some obstetric units in the state of Texas. There's only 23 surveyed so far, and the deadline is 18 months away. Tick, 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 tick. So I would advise at least getting on the list. Doesn't hurt to sign up now. You can sign up for May of 2020, but get on the list now because it's going to get a big backlog at the end, and you don't want to be left out in the waiting. And that's all I had. So.
Do we have any questions from the audience?
You guys are comfortable with this. Awesome.
Anybody have a good survey story they could tell?
So each of them know me. Just two things I would like to call out. It was a great experience. It is a delightful forcing function to be better, so you have to look at it that way. But two areas that I think that are in the elements that you must meet, I don't want us to forget our midwifery colleagues because some of the elements really talk about that practice, and so they're somewhat between the provider bylaws of the hospital and APRN practice, and they do need to be instrumental in your QAPI. I would suggest getting with them and helping to guide them because I think at times they feel like they're covered in the provider elements and they may not be, and so you really have to ensure that they're there. And because our adult medicine and surgery colleagues are not with us today, they need to be your friends. You need to know each and every one of them really well, and they also have to have a QAPI process because one of the elements is that they need to be with you within 30 minutes of an urgent request. And that is not part of their bylaws per se. Some hospital bylaws right now say that they have to be at the hospital in 45 minutes. So that came up this week in a discussion that we had at our RAC, and so I think that that's something you should look into. We did help guide them. Dr. Davidson and I created their QAPI statements for them, and they've done a wonderful job, but you will have to be able to ensure that they can be with you and assist you. So I just don't want to forget those two groups of people. They're really important. And thank you. It was great. We really enjoyed the summer together. But it is a really, really important experience for everybody to go through. Thank you.
Thank you.
Can I ask you a question, actually, before you sit down? So as a nurse midwife who's involved in the QAPI committee, can you give me an example of where I might not fall under provider and when I might fall under APRN or how that might be different? Because I haven't come across that, and that's concerning.
So I can't even tell you what line it is. It might be like number 72 or something. We called everything a line item, but it specifically states that the midwives have to have a QAPI program of their own. So that is a chart review or a goal. So one of our goals, I can tell you, the way we wrote it, is that for their urgent request for a physician colleague to come to the bedside for them, that they have to meet that within 30 minutes. I think that's an element. And so what we did is that quarterly we sample, they review all their charts monthly anyway. We created a document that said that they reviewed the chart, the time that they called that it was documented, the time that the person came to the bedside and it was documented, and if they reached that element. So we've gone through 2 quarterly reviews of this so far, and each time they have. But then once it's 100%, we'll choose another quality indicator. So you have to have a program, and then you have to demonstrate that you actually do it, and then you have corrective action for it.
I would also add ours, so if you're the primary provider for a patient, you have to be there within 30 minutes. And then at least within my own facility, we hadn't made all of the grand rounds and everything mandatory for our midwives. It was for residents and attendings, and that was a major gap for us, that they weren't getting exactly the same education, even though they were dealing with the same high-risk patients. So making sure we look seamless in the opportunities and education and things to participate in.
Yes, and that's, so that's where we treat, as we should, our midwives as providers. So we actually didn't have that gap, because in all of our needs assessment and education, department meetings, the midwives are all included all the time, and we had them on the sign-in sheets. So we didn't have, that was the difference between the two that we talked about actually when we were preparing. Is that it?
Okay, yes, thank you.
We've got time for one quick question.
I have a quick question. Thank you. This was a great panel. I'm curious, since I run a group of people who are trained to be surveyors of milk banks, and we struggle to eliminate surveyor by surveyor differences. Can you speak to those of you who have done the surveys already? Can you speak to how different the surveyors are, and if you have surveyed another unit, how you are trained to not only assess according to the standards, but to be uniform in that assessment?
Well, for either ACOG or TTAF for the maternal survey, you go through a training session, 1 or 2 day session with either of those organizations. I'm actually trained for both, and the training for both was pretty similar. The chart audit tools are very similar. As far as on the ground when you're doing the survey, the ACOG or the TTAF surveyors, the organizers are there to kind of moderate questions that arise, as well as some representatives from the state are there. At least they were for the two that I was at, mine and the one I did. So if there were some gray zones where we weren't sure about certain things, and how do we, I can read this and it sounds like they probably meet this, but what is the real intent based on what we've seen? And we just had a robust dialogue with the survey leadership group that was there, and the state group that was there, to kind of caucus and come up with the right decision. So it isn't just my opinion, and I was the lead for our survey group. It was the consensus of my other two surveyors I was with, as well as the survey organization leadership that was there, and then the state was there just in the background to provide interjection if they needed to, based on to give us guidance. So I thought it was both surveys I did, my own and when I went to Dr. Davidson's survey, I thought it was uniform. Although I've heard that concern raised, I think the process of educating surveyors and the process that happens in those debriefs behind the scenes when you're not invited is an open dialogue about what is the rule intent and what does it actually say.
And I would just say, I thought it was a very fair process at both hospitals that I was surveyed at. So I am a surveyor. I haven't gone to survey a hospital yet, but I've gone through the training. So I had, kind of an idea of what to expect from that. And then I went through 2 different MLOC surveys at 2 different hospitals with 2 different groups of surveyors. And it was very similar. They were very similar. So I wasn't like, gosh, I can't believe they asked me this. They didn't ask me this at the other hospital or anything like that. So very fair across the board, very similar processes. Again, to me, I liken it to the oral boards too. I tell everybody that, the same exact thing. And I thought my general OB-GYN oral boards were just as stressful and hard and fair as my MFM oral boards were. And so I personally don't have concerns that it's not a fair process from what I've seen and experienced.
We're going to have to cut it off there, but thank you very much for your participation. I'm sure the panel would be happy to answer any questions offline.
Okay, so we're going to our breakouts. We have about 7 minutes to get to our destination. For the OB, you're staying here, so that's not a problem. For our neonatal group, if we can go to room 103, and the community health, room 104. So going up the escalator, you're going to turn to the right. It's going to be on your right, and we will direct you if you have any problems finding it. Another thing is we want to be back here at exactly 2:50.